Hi, my name is Kathleen Dungan. I'm an endocrinologist at The Ohio State University, and we are going to discuss the interpretation of continuous glucose monitoring reports in the typical primary care patient. This is a case-based approach. And the objectives are to identify the basic elements of the standardized report, which is called the ambulatory glucose profile. We will use CGM examples to identify some common glucose patterns, and we'll address some of the common pitfalls in interpreting CGM. As a way of background, the whole reason for implementing CGM in your practice is to improve glucose control. And in patients with type 2 diabetes, in particular, clinical trials have demonstrated reductions in hemoglobin A1C, also improvements in the time in target range, which is generally defined as 70 to 180 milligram per deciliter. A lower risk of hypoglycemia has been observed, and there are positive effects on patient satisfaction and some emerging data suggesting a lower risk of diabetes-related hospitalizations in those patients who are utilizing continuous glucose monitoring. And as a result, it has been increasingly covered and has been utilized more and more widely in primary care practices and in other specialty practices as well. In fact, both Ohio Medicaid will cover patients with diabetes, and Medicare has recently expanded its coverage to individuals who are needing at least one injection of insulin per day. So in terms of how we can assess overall glucose management, the American Diabetes Association has made some fairly recent changes in their guidelines for assessing glycemia. Whereas previously it nearly exclusively revolved around hemoglobin A1C monitoring, in the last couple of years, this has been revised to include CGM metrics, which are, as I'll describe, include the time in range and the glycemic management indicator. And that's just an estimation of the hemoglobin A1C derived from CGM data. Any one of these metrics can be used to assess glycemic control, and the frequency of assessment depends upon how close the individual is to meeting their treatment goals. And these are the more detailed metrics that you will find on a standardized report. In particular, it's important to understand how long the device was in wear and what percentage of time the patient had active data. And the reason for this is because, on average, approximately 70% of the glucose values available from a 14-day report are needed to have an adequate assessment of A1C and to estimate that using the glycemic management indicator. And as follows, there are other metrics that can be utilized. The glycemic variability metric is the coefficient of variation, and the goal there should be less than 36% if possible. We know that higher glycemic variability indexes indicate a higher risk of hypoglycemia. The percent of time above the target at 180 to 250 or above 250 are also considered part of the time above range, and those goals will vary. The time in range, as mentioned previously, is the percent of time spent between 70 and 180 milligram per deciliter. And then finally, the time below range is defined as less than 70 milligram per deciliter for level 1 hypoglycemia, and less than 54 milligram per deciliter for level 2 hypoglycemia, which is considered to be more clinically significant. And these goals will also vary depending upon the attributes of the individual. So, this is an example of what the overall goals might look like for people of normal risk. And these might be individuals who are at relatively low risk of having a severe hypoglycemic event, or at least low risk of having severe outcomes from a hypoglycemic event. These are generally younger individuals with fewer complications and or comorbidities. And in those individuals at higher risk, those targets are adjusted. So you can see on the left side, the time in target range is generally over 70%, and the goal for hypoglycemia should be less than 4% for that cutoff of 70 milligram per deciliter. And then for those older or higher risk individuals, a time in target of greater than 50% and an overall hypoglycemia risk of less than 1% are adequate and considered acceptable. Now, this is a snapshot of the different components of a typical ambulatory glucose profile, or AGP as an abbreviation. You can see your basic statistical measures like your average glucose, and then the time below, in, and above ranges here. In this case, this example is a little bit below target for any definition of whether you're looking at relaxed or more tight glucose levels. And the coefficient of variation is fairly standard. And if you look on the far right there, we can see that in this particular report, there is pretty good data sufficiency, which is generally considered acceptable if it's over 70% on that 14-day report. And then in the graph to the bottom, this is sometimes represented slightly differently, but in general, it represents the amount of time that the individual is spending in a particular glucose range. In general, there's a median line, and there is a 25th to 75th interquartile range in the orange line and between the two blue lines, respectively. And so this really helps to eliminate some of those outliers and help you focus on what kinds of patterns there might be that could be actionable. And then finally, the more granular details can be inferred from those green lines, which give you the 10th to the 90th percentile. And there's usually a marked area to delineate the 70 to 180 milligram per deciliter target range. So these are just a few pointers. When you're looking at a report, it can be kind of overwhelming. There's really a lot of data. So what would be a standardized approach that you could use? Some of this is taken from just my general background and experience with looking at these reports, but there's also other expert guidance that you can read about. For example, I've provided a reference to you here from the American Association of Clinical Endocrinologists. In general, I like to look at medication taking behaviors. First of all, you don't want to be making adjustments to medications when the individual is really not taking their medications regularly. You want to look at meal times. Are they having snacks? And in particular, in that overnight period, because that's really important for assessing whether or not your overnight control needs an adjustment in the long-acting insulin or other factors that might be impacting the morning glucose. Then I would move on to the overall glycemic status. It's their overall time in range and average glucose in a reasonable level. Then really focus on hypoglycemia. Oftentimes, if we get rid of hypoglycemia or excess hypoglycemia, that can set the stage for more stable glucose levels. And then assess the morning glucose levels. Again, being careful to think about if those are fasting or not fasting. And then move on to the postprandial or non-fasting glucose levels. You can then interpret these based upon the individual's physical activity. So moving on to our cases, this is case number 1, and this is a 52-year-old female who's otherwise reasonably healthy. Body weight is 90 kilograms. Her current management includes metformin, glimepiride, dulaglutide, and glargine U300 at a pretty reasonable dose of 60 units per day. And you can see a couple of basic elements of the CGM report are included here. Overall, there is a reasonable amount of data as shown in that light blue box there. We have about 76% of the data. The overall glycemia is above target for this individual, which we would try to aim for an A1C of around 7% or less. We can see that also in the time in target range, which is only 35%. But thankfully, there's no hypoglycemia here. And then when you actually look down to the graph of the ambulatory glucose profile, you can really clearly see their patterns here is predominantly postprandial hyperglycemia. And in particular, note that there's a big differential between the bedtime glucose and the morning glucose. So further titration of that glargine would be unnecessary and potentially lead to more hypoglycemia. So in this case, what an acceptable strategy would be to potentially titrate that dose of dulaglutide as tolerated up to the maximal dose. You could probably stop the glimepiride at this point, or at least consider reducing it to reduce the risk of hypoglycemia, and then start a dose of short-acting insulin at the largest meal of the day. And we can expect to get about 50% of patients to goal with this strategy alone. But further increasing that basal insulin is not going to be the most effective strategy here. Here's our second case. So this is a 29-year-old female with type 2 diabetes. She's currently treated with empagliflozin, glargine 45 units, and Lispro using a correction dosing, otherwise known commonly as a sliding scale, and just has some intolerance to other medications like GLP-1 based therapies and metformin. And as we look at some of the important elements of this report, we can see, first of all, number one, that the glucose time in range is close to goal. We would want her to be close to 70% or more in time in range. She's having quite a bit of hypoglycemia, however. We can see then that 54 to 69, spending 6% of the time there, and then spending 3% of the time below that. And then this particular device download has a specific call out for hypoglycemic events. You can see that on number 3 in your figures. And so those are predominantly occurring in the early morning hours. So in this case, this is a classic example of someone who just over-basalized. And we just need to utilize the short-acting insulin a little bit more effectively by giving that on the front end with the meal rather than only correcting the glucose levels with insulin when the glucose is already high. And then we would want to reduce the glargine to get that hypoglycemia down to a more reasonable target range of 4%. Here is case 3. This is a 52-year-old male who has chronic pancreatitis and, in fact, has a C-peptide that is low or on the low side of normal. Also has coronary artery disease and heart failure. This patient is currently on basal bolus insulin therapy. There are some important points to point out on this report. In particular, we have, first of all, number 1, we have adequate data. Number 2, we have a fairly reasonable percent of time in range given his comorbidities. We have a pattern that shows this postprandial hyperglycemia, but then lots of hypoglycemia at bedtime. And so this requires a little bit more investigation as to really what's going on here. This is another report called an overlay report that we can see on some of the different types of downloads, which is really useful and can add a little bit more insight. So in this case, the patient is, really not getting enough insulin with lunch. And so we can see that very clearly. So we can increase that mealtime dose of insulin. And also importantly, with talking to the patient's often seeing these high glucoses post-meal, getting an alert and giving extra corrections. And so we discussed avoid giving those post-meal corrections because they're oftentimes overcorrecting. We also referred the patient to education. Now, in this case, we could potentially, since this patient has diabetic nephropathy, we could perhaps consider an SGLT2 inhibitor, but I would be very cautious with the low C-peptide given that risk of DKA. Case number 4, this is relatively brief case just to illustrate how CGM might be utilized quite effectively in an individual who's not needing insulin. In this case, an individual was just on oral medications and not taking their semaglutide. The overall time in range is 47%. The GMI is not reported because in this individual, there wasn't at least 12 days of data, which is required for this particular software. And then if you look on the right-hand side of the screen, this is in the weeks following the implementation of semaglutide. All of a sudden, you see this time in range go up to 87%, and this is equivalent to an A1C estimated at 6.8%. But you're seeing these results a lot sooner than you would with just an A1C alone, which is generally going to take several months to really reflect the steady state. And case number 5, a little bit more detail about this individual is a 65-year-old male with type 2 diabetes and chronic kidney disease. The patient had been receiving empagliflozin, but it was discontinued due to balanitis. This individual is very astute and in tuned to their glucose levels and monitoring them very closely. And so they became very concerned as they started to see some hyperglycemia develop. And when we look at the reports, you can actually obtain a comparison from the previous 2 weeks. So indeed, this individual's glycemic control is not quite as good. So the time in range went from 81%, which is near perfect, to 73%, which we would probably still find to be acceptable and actually very good, considering that the individual has chronic kidney disease and that there's no hypoglycemia. When we look at, however, the daily overlay reports, this is from a 1-week period, we can see a little bit more granularity. So here are some important findings. So first of all, there is some overnight hyperglycemia. This individual's running about 180 or so overnight, which is clearly elevated. But then at morning, the individual's getting their glucose levels and really working hard and actually giving some additional insulin, short-acting insulin doses to try to get them down. And so this individual's actually overcorrecting their hyperglycemia. We see more hyperglycemia later in the day. The individual's not eating lunch here, and so it's just more of a steady basal-like period. And then again at dinner, kind of seeing a similar pattern, trying to overcorrect. So the answer here is a little bit more complex. I would actually increase the Detamir, the long-acting insulin, slightly, but advise the patient to bolus pre-meal and don't perform extra corrections post-meal. So this individual should be able to get back to the level of glucose control that they had previously. And this is case number 6. This is actually a younger patient, an adolescent, who has been trying to lose weight by skipping meals, and in particular that breakfast meal. The fingerstick glucose levels were infrequently being monitored, and a professional CGM was placed, and this is a device that is owned by the clinic and not the patient. The patient's current treatment is metformin, glargine, and Lispro with meals. We can see the download from the first period of sensor wear here. This is from an individual day rather than the typical ambulatory glucose report that you can see. So in this kind of report, we can see where alarms are going off and or where there are particular events entered by the patient. But if you look at the red boxes here, the patterns that we can observe on just one day that can be actionable and discussed with the patient includes this morning glucose level is gradually rising. The patient's not eating anything, but you can see that it's gradually rising. This is very common with the dawn phenomenon and actually pretty pronounced oftentimes in adolescence with a rise in growth hormone and cortisol in those early morning hours. The second pattern is the individuals not eating breakfast and or maybe having a small breakfast and just not covering it, resulting in persistent hyperglycemia. And then that initial postprandial rise in glucose after lunch due to a late insulin dose, and sometimes this could even be a missed meal dose, but in this case it was a late dose, and because it was poorly timed, it actually resulted in hypoglycemia later in the afternoon. Then the hypoglycemia was treated, probably overly treated, and resulted in rebound hyperglycemia, number 4 on your graph. So these are patterns that can be addressed and helping the individual learn how the day-to-day behaviors can impact glucose levels. And so we would encourage this patient to have regular meals, including breakfast, dose the insulin pre-meal, and depending on the type of insulin for your typical Lispro, Aspart, and or equivalent, 15 minutes is generally ideal. And then also encourage the individual to start personal CGM device so that way they can use these patterns to help them make day-to-day decisions and also to help warn them early and effectively prevent hypoglycemia. Now, this is case 7. This is a 70-year-old female with type 2 diabetes with neuropathy and retinopathy. The A1C is quite high at 10%. This individual has some self-reported glucose readings in the 100s, which seems relatively good, but it doesn't match the A1C. So this would be a great time to refer the patient to diabetes education and start the individual on a continuous glucose monitor to really understand what is going on to cause this discrepancy. Now, when we get the report, we can see that the glycemic management indicator 7.9%. So overall, the CGM data is lower than what was obtained with the hemoglobin A1C. But this is not in isolation because the patient is now seeing this data and able to act on it. In general, the patient has glucose levels at target less than half the time, so that's a bit low still, even with this improvement in glycemic management indicator, estimating the A1C. And then if we look at the graph itself, we can see, first of all, some overnight hyperglycemia, but importantly also some relatively short-lived postprandial spikes. And when we discuss this a little further, we discover this is from snacks that are in between meals. So first of all, in this individual, just implementing CGM alone brought their A1C from 10% down to an estimated less than 8%. So we really want to acknowledge the success that this individual's had. And then we want to talk about how do we deal with some of these interprandial spikes. And so one opportunity would be to add a snack time dose, which some individuals would be okay with, even if it adds to the complexity. And in this case, that's really what this individual prefers. And we weren't really aiming for substantial weight loss, although that should be an important consideration. And then finally, case 8 on the Freestyle Libre 2 and the Freestyle Libre 14-day. These are the not the Freestyle Libre 3 devices. There is a need for ongoing scanning of the device in order to obtain all of the glucose data on the report. And in particular, the memory is only about 8 hours long. So if one is not scanning at least every 8 hours, there can be gaps in the reports. And this is just one example of what that gap might look like. So it's really hard to make decisions based on the data that we have here due to the missing data. So keeping that in mind and always just trying to remember to remind your patients. And this is another kind of pitfall that we can sometimes see. And these are another type of gap in the data. You can see this more. This is, again, an overlay report where we have each individual day in a week that's overlaid in an individual graph. And you can see these parts where the data just drop out. In a couple of cases, it makes it look like there's hypoglycemia here. But most likely, this is some kind of artifact. And so there are a few things that an individual could do. First of all, they want to make sure that none of this is due to the loss of the signal. So if the transmitter is somehow out of range with the receiver, that the sensor is not being compressed. And if not, it could be a problem with the sensor, so the patient could change out their sensor. And worst case, they could consider whether or not the transmitter might be an issue as well. So these examples of CGM reports hopefully can help you understand some common patterns that we see that can help patients make lifestyle changes and or help with making adjustments to medications. And using a systematic approach can be useful to really account for all of this data and be able to address even more than one or two common scenarios. These are some cardio resources that may be helpful to you on the Cardi-OH website to learn a little bit more information about type 2 diabetes management and our references. And with that, I will thank you for your attention.